بالنسبه للريسك فاكتورز سوسايتي اوف يوروجينيتال راديولوجي ريكومنديشن قالت ان النيونيت والانتستيشنال ديزيز او الجي اف ار اقل من 30 والادفانسد ليفر ديزيز او الاندستيج ليفر ديزيز ده من احد الريسك. الجزئيه الثانيه لو انا بعمل روتين انفستيجيشن يعني عندي هو عامل لسه جادولينيوم سبيشال لو في اي ديجري من رينال امبيرمنت ممكن الاقي ما يسمى السودو هايبوكالسيميا، ممكن الاقي عنده الكالسيوم بتاعه 4 هو اسيمتوماتيك. لو عدت الكالسيوم ده بعد من 3 ل 6 ساعات حسب الديجري اوف رينال امبيرمنت هيطلع نورمال. يعني ما استعجلش ان انا اصلح كالسيوم لانه ده بيبقى سودو هايبوكالسيميا بسبب الانترفيرنس اوف جادولينيوم مع الكالسيوم اسيد. شكرا جزيلا.
دكتور استاذنا دكتور صبري والدكتور احمد شورت كومنتس. keep it short please.
ملح قوي وجعني قوي. ليه لما بنطلب ام ار اي الدكاتره بتوع الاشعه لما بيلاقوا السيرم كرياتين 1.5 او 2 بيرفضوا ان هو يعملوها؟ انا مش فاهم ايه الراشونال في الموضوع. حد يقدر يفيدني؟
we all suffer
حاولت
من
اسال
الاشعه.
كتير.
We suffer from the radiologist. They also they refuse to do biopsy in a 12 centimeter kidney because of echogenicity. This is a very strange attitude nowadays.
يعني السؤال اللي انا بساله ده في محله ان مفيش داعي انهم يعملوا كده يعني، ولا في حاجه احنا مش فاهمينها؟ مش
They should listen to nephrologists because this is our specialty. Do it, you do it. It's my responsibility.
Just in response to the radiology, it is our job. They don't know basically. But my question, if the hemodialysis will clear the gadolinium, there is no debate, and which is very questionable because we can give it undialyzed. But actually this is not correct. And the second, even if it is cleared, the toxicity will not vanish. And the reason for that is gadolinium is not the preferred dye for end-stage renal patient on dialysis with no urine. And if the dialysis will help, this patient will not develop a nephrogenic systemic fibrosis, which is actually more pronounced in the dialysis population. So we use the angio more better than the gadolinium. If one of the eminent speaker can respond.
I think in the stage of CO5, before dialysis, we can use, but with precaution, if there is no precipitating factor, if there is well good hydration, and if there is urine output, well urine output. In CKD5D, we can use also, but with caution in on oligoic patient because of possibility of nephrogenic systemic fibrosis. As Professor Ahmed Adam said, it is cautiously be used if the patient is anemic.
This is emphasized that dialysis will not help to remove gadolinium toxicity. That's what I meant.
Back again to this point, no, gadolinium-based contrast agents are dialyzable because they are hydrophilic and of small molecular weight, and they don't bind to the plasma protein. And the recommendation is to use dialysis following the procedure, and this is by the Canadian as well as the American College of Radiology. But as regard to stage of 4 and 5 pre-dialysis, they are not recommending because, in spite of being dialyzable, because there is lack of evidence to support these.
The last presentation in this session is Rituximab preferable to Cyclophosphamide for treatment of membranous nephropathy. Cons Dr. Eman, Professor Dr. Eman Sarhan and James University. Pro Professor Dr. Mona Rojdi.
Thank you for inviting me for this talk. This is a very important debate, I think so. And I think I have the difficult job because I have the cons for Rituximab in treatment of membranous nephropathy. Please, not the, no, there are. Yeah, this is for Dr. Mona. Thank you. Okay, Rituximab is preferable than cyclophosphamide in membranous nephropathy. I will talk about the cons. Actually, I will start by that membranous nephropathy is the most common cause of nephrotic syndrome in adult and usually characterized by thickening of the glomerular-based membrane, subepithelial deposits in electron microscopy, giving a characteristic spike in silver stain. The most important cause is the primary membranous nephropathy, previously called idiopathic. It is occur in 75 to 80% of cases. It's usually now related to, divided into two parts, like pilar-associated membranous nephropathy with the presence of antibody against the M-type phospholipase receptor in 70 to 80% of cases, and non-pilar-associated membranous nephropathy in which a lot of autoantibodies is present, and secondary membranous in 20 to 25% of cases, secondary to infection, second to oncology, malignancy, drugs, and so on. The most important is the presence of anti-pilar. The disappearance of pilar from the circulation is an important, for inducing what's called immunological remission. What's meant by immunological remission? This disappearance of pilar and followed by clinical remission by disappearance of proteinuria. And here, anti-pilar is a good prognostic biomarker in membranous nephropathy, and we found that low titer of pilar is associated with remission, and high titer of pilar is associated with progression. Actually, when we leave the patient with membranous nephropathy, we have 5 to 30% go complete remission, up to 40% reach to partial remission, and about 30 to 70% go to nephrotic syndrome, and this is go to end-stage renal disease by 35% in 10 years, compared to only 2% of patients with non-nephrotic range proteinuria go to end-stage renal disease. First, we need to stratify the patient to know the risk stratification for patient with membranous nephropathy. We categorize patient to low risk. Low risk, it means normal or stable kidney function, proteinuria less than 4 gram, and anti-pilar is less than 50 relative unit per milli. Moderate is normal or stable kidney function, proteinuria from 4 to 8, and pilar less than 150. Severe high case or high risk is non-stable kidney function, decrease in GFR by more than 25%, and proteinuria more than 8 gram, and pilar more than 150. We can also have a very high risk for progression, and this when we found 2 or 3 at time of diagnosis, but the other is present during the follow-up period from 3 to 6 months. And we found if creatinine more than 1.5 and decreasing the kidney function and persistent life-threatening nephrotic syndrome. Actually, our target is to induction of remission, either complete and or partial, and this will translate it to improve kidney survival follow-up. This is our tool for getting a remission in this patient: cyclophosphamide, rituximab, cyclosporine, together with corticosteroid, and also don't forget the conservative treatment, which must be applied for all patients. This is a landmark study which done for patients with membranous nephropathy. Starting that membranous nephropathy described in 1946, then Hammond nephritis described in 1959, Steroid started in 1979, then Ponticelli in 1984 tried steroid like plus chlorambucil plus symptomatic versus symptomatic treatment. Then Ponticelli in 1998 tried cyclophosphamide in comparison to chlorambucil. Then mycophenolate MMF started in 2007. Then discovery of Pilar in 2009. Then Rituximab versus placebo in 2017. Then Rituximab versus CNI in 2019. This is a studied group by the doses. And this is, we'll go to the study. We found remission rate in cyclophosphamide group is 83% versus 38% in conservative treatment. And this gives 10 years renal survival, about 92% compared to 60%. In Rituximab, a small study shows that partial or complete remission reach 50% in 6 months and can be reached to 60% in 12 months. This is a study done for Rituximab, and already Rituximab show, this is a study, Rituximab to induction of remission 64%, number of non-responder is 36% and relapse 30%. Comparison between Rituximab and cyclophosphamide, that partial remission was lower in Rituximab compared to cyclophosphamide, and they conclude that Rituximab is inferior to cyclophosphamide. This is immunological remission, and immunological remission in cyclophosphamide here is reaching disappearance of antibody regardless of the baseline level of Pilar. But in contrast to Rituximab, we found that it's difficult to achieve disappearance of antibody, especially when Pilar more than 152. In very high-risk patient, immunological remission is high in cyclophosphamide, 86% versus 23% for Rituximab. And KDIGO guideline 2020 described cyclophosphamide for high-risk patient, and both also cyclophosphamide for a high-risk patient. And here also, in patients with resistance and have low GFR, they described all cyclophosphamide for those patients, and also for patients with not responding to other measures, they describe for them cyclophosphamide. So, because the efficiency of Rituximab in patients with kidney insufficiency is improving. Study done for Rituximab, they found that patient with serum creatinine 2 and tubular interstitial score more than 1.7 has lower response. So Rituximab has limited benefit in patients with severe kidney injury. This is our remission. Cyclophosphamide has higher renal survival, 92%, higher immunological remission, 86%, recommended by guidelines for a very risky patient, resistant patient, patient with low GFR, and it is a cost effectiveness. So my message, there is sufficient evidence to support that Rituximab is not preferable than cyclophosphamide in membranous nephropathy, especially in patients with very severe or high risk for progression to end-stage renal disease, resistant to other treatment, has lower GFR, and this is my message. I know that it's difficult to use it till now, despite the side effect, but I think good doctor make good stratification for the patient and advise the proper medication to reach its target. And thank you.